Good morning. I'm Gautham. Today I'm going to talk about an overview of patellar instability. So, patellar instability, it is a condition whereby there is a patellar dislocation or subluxation occurring as a result of injuries. There is a ligamentous laxity or increase in Q angle. There are a few risk factors that contribute to patellar instability. So, it may be general factors or anatomical factors. So, the general factors is because of ligamentous laxity, and in such you can see in Ehlers-Danlos syndrome. Previous event of instability, or maybe there is an injury previously, and also a miserable malalignment syndrome, which is a triad of femoral anteversion, genu valgum, and also a pronated feet, which can lead to patellar instability. For the anatomical factors, we have osseous and also muscle causes. So, for the osseous causes, it is such as the patella alta, trochlear dysplasia, and also lateral femoral condyle hypoplasia, which may lead to patellar instability, and also muscle causes such as a dysplastic VMO, vastus medialis oblique, and also overpull of the lateral structures such as the iliotibial band and also vastus lateralis. So I will talk about the pathophysiology. Firstly, the mechanism of injury. Usually it is a non-contact twisting injury with the knee extended and the foot externally rotated. There could also be a direct blow, for example in basketball, where there is a knee-to-knee collision causing a traumatic incident. So I would like to talk about the stabilizer for the patella, which we can divide into the passive and also the dynamic stabilizer. So for the passive stabilizer, we have the MPFL, which is the medial patellofemoral ligament, and also the patellofemoral bony structures such as the trochlear groove morphology, patella height, and also the patella tracking. For the dynamic stabilizer of the patella, it is provided by the vastus medialis muscle. So to classify these injuries, I would classify them as acute traumatic, and then they can be chronic patholaxity, and also habitual dislocation. So as we examine the patient, the presentation of the patient is usually they will complain of instability and also anterior knee pain. So we should do a general knee examination, and there are additional special findings for these patients. Firstly, there might be a large hem arthrosis in case of acute traumatic injury. Okay, and then there might be a medial sided tenderness over the MPFL. There might be increase in passive patella translation, which is more than 2 quadrants, and also patella apprehension can be appreciated in the patient, in which we provide a lateral pressure, and we see whether the patient has any apprehension. Of course, there might be an increase in Q angle when we examine the patient, and one more significant finding might be the positive J sign, which is excessive lateral translation of the patella in extension, which pops into the groove as the patella engages into the trochlea in flexion. So to investigate the condition further, we can do a few imaging methodology to rule out any fracture or intra-articular loose bodies. Okay, so a few views can be appreciated in this situation. A first AP view to see the alignment and overall version of the limb, and the lateral X-ray, which is very important to see the trochlear dysplasia, which it may inhibit crossing sign, double contour sign, and also you can appreciate a supra-trochlear spur. There is another view we can see, which is the true lateral view and 30 degrees of flexion to appreciate the patella height. Mainly, we are seeing patella alta versus patella baja. So, a few of the methods to quantify is Blumenset line, Insel Salvati method, and Blackburn peel. So this we will discuss in the future later lah. So another view is the merchant view, or also known as the sunrise view, which we are taking. It's a superior inferior view of the patella, which is taken at the long axis of the bone. In this view, we can see appreciate a lateral patella tilt. We can measure the congruence angle and also the sulcus angle. Other imaging modalities include CT scan, which is to see the TT-TG distance, which is the tibial tubercle to the trochlear groove distance, and also MRI is indicated to further investigate a tear of the MPFL or to look for any intra-articular loose bodies as well. So for the treatment, we can go non-operative and operative. So for the non-operative, usually we will give NSAIDs, enough rest, and also immobilization, which is short term, maybe about 2 weeks with a cylinder slab in case of the acute injury, and we should focus on strengthening. So for this patient, we go up for closed chain short arc quadriceps strengthening, and also to core and hip strengthening exercises to improve the limb positioning and balance. We should also target the hip abductors, gluteal and abdominal muscles. There are also some adjuncts which we can use for this instability, such as the Patellar brace, which is known as a J brace, and other adjuncts such as kinesiology taping. For the surgical method, we have arthroscopic debridement, MPFL reconstruction if it is torn. There is also tibial tubercle distalization, lateral release, and also trochleoplasty. Lastly, I would like to say there are 2 complications of this condition, which may be recurrent dislocations, and also it may lead to medial patellofemoral arthritis in the future. Thank you.